topic is important because it is one of the most devastating disorder and second leading cause of death worldwide right now, including the developing countries. And it is most important reason for disability and dependence in adult population. And as population ages and also the prevalence of risk factor is increasing, the disease burden of stroke is going to increase and timely intervention can reduce the further burden of disability. So let's see this case. He is a 65-year-old male. He presented to ER at 4 p.m. with history of sudden onset weakness of left upper limb and lower limb. And he has got history of slurred speech. He is also a known case of hypertension, type 2 diabetes mellitus, on regular treatment. He is on statin but he is not on any antiplatelets. How will you proceed further? So time is break and you need to be fast. Every hospital may be a small 20-bedded, 40-bedded, 100-bedded hospital. Every hospital should have a code designated to such emergencies like acute stroke. Because you need to be very fast. Nowadays, even smaller nursing homes, they are thrombolizing patients after doing simple plain non-contrast CT scan. So door to needle time should be as less as 60 minutes. So will you do the initial assessment? And why the initial assessment is important? To know the differential diagnosis, because there are many stroke mimics. Patient may come to you with simple seizure, post-ictal phase. Patient can come to you with hypoglycemia, even hyperglycemic coma can present like stroke, even migraine can, hemiplegic migraine can present like stroke. So you need to know the differential diagnosis. Then you need to know the exact extent of the damage and which part of the circulation is involved. Whether it is posterior circulation, whether it is anterior circulation, and how much is the damage. If the damage is very less, you may not thrombolize the patient. If on the scoring basis, the score is very less, but if you feel that no, the disability is going to be very high, suppose the patient is only aphasic, but then there is no motor power loss, you are going to thrombolize, even if the NIHSS scale is less. And then you need to know the contraindications for thrombolytic therapies and also whether the patient is on any anticoagulants or antiplatelets. So initial assessment, it should not take more than 5 minutes. In here, initially don't examine the patient in detail but be fast. See whether the patient has got imbalance, whether the patient has got double vision or blurred vision, whether there is facial drooping, whether there is arm drifting, whether there is slurred speech. If anything is there, then just activate the code in your hospital, whichever code is there. This one scale is there, which there are 11 items and they add up to around 42 points. This scale is also important. You should have that chart in your ear. But it is very difficult to, just on the basis of this scale, it is very difficult to designate whether this is mild, moderate or severe stroke. However, they say that if the score is up to 5, it is mild, 5 to 9 or 10, it is moderate, and anything 10 or more is severe stroke. Why this scoring is important? Because it correlates with the stroke outcome. The more the score is, the less better is the outcome. Its use is recommended in all patients with suspected stroke. As I already told you, find out which territory is involved. Because in future, suppose your thrombolysis fails, or even if you have thrombolized the patient and if you have got facilities for mechanical thrombectomy, all patients, even if they undergo intravenous thrombolysis, they must be subjected to CT angiography or MR angiography, find out whether it is a large vessel stroke in anterior circulation, and then subject those patients for mechanical thrombectomy. And if you don't have facility and if the patient is affording, shift the patient for mechanical thrombectomy to other facility. So find out which territory is involved. Don't go into all those stroke syndromes, smaller vessel, that clinical diagnosis which we learned during our residency, that is not required, but just find out which part of the circulation is involved. So these are the goals in initial phase. First is ABC. In every patient who is coming to your ER, he may come to you with simple muscular pain. Start with airway, breathing and circulation. The quickly reversing of any condition that are contributing to patient's problem. For example, if it is simple hypoglycemia, you correct the hypoglycemia, symptoms are gone. Certainly, this is not the case where you think about those measures. Determining if the patient with acute ischemic stroke are candidates for intravascular or intravenous thrombolytic therapy or endovascular thrombectomy or both. The next goal is moving towards uncovering the pathophysiologic disease, whether it is embolic stroke, whether it is thrombotic stroke, or whether it is something else. And the ultimate goal is to minimize the brain injury and ultimately to minimize the disability as far as the modified Rankin scale is concerned. So rapid examination, ABC, because suppose the patient has got posterior circulation stroke. Airway may be at stake. So always think about airway breathing circulation. Patient might have aspirated, patient may need oxygen. But it is not required that you give oxygen to all the stroke patients who are coming to you and they are not hypoxic. So this is the rapid examination. Don't waste too much of time, but yes, blood pressure, always check for pulse and heart rate, whether patient has got atrial fibrillation, look for the carotid bruit, look for the murmurs, skin signs of infective endocarditis. Certainly some clinical signs are always important even in ER. Look for purpura or ecchymosis if they are present. It means that patient may be on some oral anticoagulants or patient may be having some bleeding diathesis, patient may be having some thrombocytopenia. There may not be anyone who can give you the history. Expose the patient, look for the scar marks of surgery. If they are fresh, patient might have undergone surgery recently. Look for the fundus, signs of trauma, and tongue bite. Tongue bite can tell you whether patient had some seizures recently. First thing first, do non-contrast CT of the brain first. Non-contrast CT is the investigation of choice. Check the finger prick, blood glucose, oxygen saturation, ECG, send CBC. Don't wait for its report, but send CBC, PTINR and MPT. These are the basic tests. You don't need too many other tests. However, thrombolytic therapy for ischemic stroke should not be delayed while awaiting the results of hematology. Unless the patient has received or is known to have received anticoagulants or is on anticoagulants for maybe atrial fibrillation or past DVT or whatever, or patient is a known case, somebody tells you that yes, he has got ITP and his usual platelets are say 50-70,000. Otherwise, don't wait for these hematological reports. The only test that is mandatory before initiating intravenous thrombolysis is blood glucose. If blood glucose is normal, don't wait for any other reports. Just take the history, patient is an ideal candidate, thrombolyze the patient in here. Fluids in initial assessment. Have to wide bore peripheral cannula and give only normal saline. And why only normal saline? Don't give any hypotonic fluids. Why these patients may need fluid? They may be hypotensive. You don't know. They may be hypovolemic. And if the patient is hypovolemic, the cerebral circulation may get affected. So give good amount of fluid to these patients. Treat hypoglycemia, treat hyperglycemia. Check for this following. Keep the head and body position in neutral position. If there is fever, treat that because fever may worsen the outcome and have activated stroke area. So, next is neuroimaging. You cannot waste too much of time, so only CT scan of brain plane. Neuroimaging should be obtained for all patients suspected of having acute stroke or TI. The brain and neurovascular imaging plays an essential role by differentiating ischemic stroke from hemorrhagic stroke. That is the first goal, differentiate. Also, it excludes stroke mimics. It helps in assessing the status of large cervical and intracranial vessels. It helps in estimating the volume of brain tissue that is irreversibly infarcted, that is infarction code. It helps in estimating the extent of potentially salvageable brain tissue that is at risk, that is ischemic penumbra. And it helps in guiding acute interventions, including patient selection for different forms of reperfusion therapies. So these are the different types of imaging which are available in all big hospitals. You will have CT also, you will have MR also and everything. Multimodal CT or MR are also available in most of the bigger hospitals. But if you are in a smaller nursing home where you don't have facility for anything including CT, and if you have tied with some or other CT centers, always have some understanding. Send the patient first, get the CT plane done. CT is with you, no hemorrhage, thrombolyze the patient. But time is brain, your door to needle time should not be more than 60 minutes. So CT or MRI for initial imaging, so CT is best. It rules out bleeding. So it has got advantages, widespread availability, even smaller hospitals, they are having CT,